Okay, so today we have the electrolyte management with respect to the critical care. Okay,
Okay.
so this is your first scenario. Kindly review it and then we will start.
Okay. Yes, sir.
Okay, so kindly tell me what is the normal level of serum sodium?
Normal level is between 135 to 145 millimoles per liter.
Okay, give me a simple classification of the causes of hyponatremia.
It can be divided into dilutional, depletional, and endocrine-related hyponatremia. Can I elaborate, sir?
Yes, with examples.
The dilutional hyponatremia can be due to excessive amount of fluids. Then euvolemic hyponatremia is due to SIADH. Then in depletional hyponatremia, it can be due to renal and extrarenal causes. In renal causes, it could be due to loss of sodium in urine. Extrarenal causes can be due to burns or GIT losses, and there could be endocrine related losses of sodium. Mm, yes.
So kindly tell me how ADH is released and what is its specific function?
Uh, ADH is released from the posterior pituitary gland in response to decreased fluid levels, and in cases of hypotension, um, leading to sodium and water retention.
Okay, and what is its function?
Mm, it prevents the loss of fluids, so there will be decreased urine output.
Okay, so what is the half-life of ADH?
So 8 minutes, I think. Mm.
Okay. So, what is the management of hyponatremia?
So the management of hyponatremia, first we have to check what is the type of hyponatremia, if it is dilutional or depletional or endocrine related, and correct it. In dilutional hyponatremia, it could be due to increased fluid levels. Increased fluid levels can be due to heart failure, renal failure like in CKD, then in liver diseases. So we can uh, go with furosemide in these patients. Then in depletional hyponatremia, we need to replenish the losses of sodium. In euvolemic hyponatremia also, we have to give extra sodium, like with like 0.9 percentage sodium chloride or 3 percentage saline. Then we have to check the vitals, because the patient can go into seizures or any confusion. So we have to monitor the patient. We have to check the osmolality, the serum osmolality and the urine osmolality so of sodium. And we can also manage according to the levels of sodium. Like if the levels is below 120, then we can give 3% saline. And if the level is between 120 to 135, then we can give 0.9 percentage saline. Yes, sir.
So what happens if you correct sodium rapidly?
Yes, sir.
Okay. So in this, the half-life of ADH is around 15 to 20 minutes.
Okay.
And the reason because for which we do not rapidly correct the sodium is the causation of central pontine demyelinasis.
Myelinolysis. Yes, sir.
Myelin. Okay. So that is why we
Okay.
have to correct it at 0.5 to 1 millimole per liter every hour.
Okay, sir.
Okay, so next we
Zero
have,
point 0.5 millimole. Okay, sir.
yes. So this is your next scenario. Kindly review it and then we will continue.
Okay. Yes, sir.
Okay, so what is your interpretation on the basis of the labs of this patient?
And the potassium level is 6.8, and the creatinine level is 650. So there is an evidence of acute kidney injury in this patient.
Okay, so this patient was inserted urinary catheter and it drained 1500 ml, then 4 liters a day. Can you tell me why?
This is because in while the patient cures from recovers from acute kidney injury, the stages are, for initially the patient will be having oliguria, then in the next stage the patient will be having polyuria, and finally the recovery phase. In oliguric phase, the urine output will be less, and the in the next stage. So this is due to the recovery of the proximal, the glomerulus, but delayed recovery of the distal convoluted tubule and the collecting ducts. So the urine concentrating ability of the kidney is lost initially. So there will be polyuria.
Okay, so why uremic patients are likely to develop
Rest of
anemia?
the sir.
Why uremic patients are likely to develop anemia?
There are four causes. The first one is the uremic pain. In uremic patients, there could be deficiency of erythropoietin, since the erythropoietin is secreted from the kidneys. Then there could be bone marrow mm, fibrosis seen in osteotis fibrosa cystica. Then there could be bone marrow toxicity to bone marrow due to uremia, and there could be red cell fragility due to uremia, leading to anemia.
Okay, so what are the functions of potassium?
Uh, The potassium maintains the fluid balance in the body. It helps in managing the neuromuscular and mm, it also helps in cardiac function.
Okay. So can you elaborate the different systems which are involved in the homeostasis of potassium ions?
The uh, renal uh, in the renal system, the absorbed in cases of hyponatremia, hypokalemia. So, potassium is reabsorbed and in exchange, H plus is secreted. Um, then mm, then it also helps in the cardiac contraction, cardiac contractility. So if there is increased levels of potassium, the cardiac contractility is decreased, leading to cardiac failure or bradyarrhythmias. Yes, sir.
Okay. So can you elaborate the action of potassium on the cardiac muscles?
It leads to dilatation and flaccidity of the cardiac muscles. If there is an excess in the potassium levels, the it helps in contraction of the cardiac muscle. So, in increased potassium levels, there will be decreased contractility. Um, yes.
Okay, so what use does the knowledge of the cardiac effects of potassium have in surgical practice?
Mm. Potassium-rich fluids can be used for cardioplegia, so that the heart gets arrested in the diastole, helping to perform surgeries on the heart.
Okay, so tell me about the manifestations of hypokalemia.
In hypokalemia, there could be confusion and drowsiness in the patient, and there could be in the ECG, the changes are tall T wave, inverted T wave, then presence of U wave, then mm, QT prolongation and ST depression, and uh,
Okay, so what are the
yes, sir.
manifestations of hyperkalemia?
In hyperkalemia, there could be cardiac complications bradyarrhythmias and decreased contractility. The ECG changes are tall T waves, then absent P waves, and wide QRS complexes. The patient can also have increased vomiting, nausea, vomiting, and diarrhea. The increased bowel movements, hyperactivity of the bowel. In hypokalemia, there will be paralytic ileus. And mm,
Okay, so what
yes,
is the emergency management of hyperkalemia?
Hyperkalemia, first, it's managed according to the CRISP protocol. I'll follow the A to E approach, and then I will, particularly, I will manage the hyperkalemia by giving the patient calcium gluconate, 10% calcium gluconate, 10 ml over slowly over 10 minutes. This does not reduce the potassium levels, but it helps in protecting the heart. Then we'll give the patient insulin. 5 to 10 units of insulin is added to 50 percentage dextrose, which is 50 ml and given over 30 minutes. Then we also give calcium resonium salts, which helps in prevention of hyperkalemia. Not calcium resonium. We help in giving a continuous infusion of calcium gluconate for maintenance. Um, then calcium insulin.
Okay, so what are the
Yes, sir.
indications if this patient is having persistent hyperkalemia and we want to get them for dialysis? So can you tell me about other indications apart from hyperkalemia for dialysis?
If the pH is less than 7.2, then if the patient is having creatinine levels more than 7, uh, yes, sir.
Okay, so in this, you were having some problem with the homeostasis of potassium. Okay,
Okay. Yeah.
so in homeostasis, we have three systems which work. That is the GIT, endocrine, and the renal.
Okay.
In the
Okay, sir.
GIT, there is a requirement of 20 to 100 millimoles of potassium daily.
Okay.
Now, in endocrine, there are certain hormones which will work to increase, and there will be other hormones which will work to decrease
Yeah.
potassium.
Yes, sir.
So,
Aldosterone and insulin.
yes,
Yes, sir.
aldosterone
Yeah.
is going to reduce it by excreting it, and
Okay.
insulin is going to reduce it by pushing it into the cell.
Pushing into the cells. Okay, sir.
Similarly,
I
with
forgot
respect
it.
to
Yeah.
acid-base balance, acidosis
Okay.
will result into hyperkalemia and alkalosis will
Okay.
result into hypokalemia.
Okay, sir.
And there is one more thing that you confuse the action of potassium into homeostasis. Like heart is not involved in the homeostasis of potassium.
Okay.
So like that's a
Okay, sir.
different question. Then you will
Okay,
tell
sir.
that what
Okay.
is the action of potassium on the cardiac muscles.
Mm. Mm. Okay, sir.
Okay, so next we have this scenario. Kindly review it and then we will continue.
Yeah. Yes, sir.
Okay, so can you tell me about the possible reasons or possible differentials in this scenario?
The possible causes TURP syndrome is a transurethral resection of prostate syndrome, in which there can be fluid overload in the patient. Should I explain more, sir?
No, that's all. So can you
Yeah.
define what
Okay.
is PURP?
TURP is the transurethral resection of prostate. Which is a surgery which is done for benign prostatic hypertrophy, uh, in which fluid is instilled, uh, which is glycine rich, for irrigation and to achieve hemostasis.
Okay. So what is the clinical picture of this TURP syndrome?
Um, in TURP syndrome, there will be uh, increased fluid levels, which can lead to dilutional hyponatremia. So the patient will be having confusion and agitation. Then there can be hyponatremia um,
Yes.
decreased urine output. Mm,
Okay.
yes.
So can you tell me about the causes of confusion in this patient?
It can be due to increased levels of glycine due to glycine and increased levels of ammonia, which is hepatotoxic and can lead to confusion.
Okay, and what is the cause of hypoxia in this patient?
Mm. Hypoxia is due to chloride shift, in which the chlorides enter the RBCs and bicarbonates are pushed out.
Okay, so what will
Yes.
be your management for this TURP syndrome?
I will manage the patient according to the CRIS protocol and the A to E approach. I will first check for the airway using the look, feel, and listen method. If the airway is patent or not, I will ensure the patient is administered with oxygen. Then, regarding the circulatory part, I will first assess if the patient is having deficiency, dehydration, or a fluid excess. If the patient is having fluid excess, I will start the patient on furosemide. Um, then, yes, sir.
Okay, so will you be giving hypertonic saline to the patient?
Yes, hypertonic saline can be given if the patient's sodium level is less than 120. So, in the circulatory part, in the CRIS protocol, I will also check for the full blood count, the hemoglobin, ABGs, urea and electrolytes, and also the serum and urine or sodium osmolality. So, then I will also check for the electrolyte levels. If the electrolyte level is less than 120, I will give 3% saline, hypertonic saline.
Okay. So what other systems can be affected in TURP syndrome?
Mm. Um, due to fluid overload, the neurological system, central neurological system, and the cardiovascular system, and also the renal system is affected. The patient can go in for a cardiac arrest or in arrhythmia. In this patient, there is bradycardia, and due to fluid overload, there could be hypertension. And in the central nervous system, there could be confusion, lethargy, and irritation, agitation. Then in the renal system, there could be decreased urine output and fluid retention. So we have to give furosemide. Yes, sir.
Okay. So can you tell me about what are diuretics and what is their general classification?
Uh, Diuretics help in removal of fluid from the body by acting on the kidneys. There are three types of diuretics. The osmotic diuretics acts on the proximal convoluted tubule. Loop diuretics acts on the thick ascending loop of Henle, and the um, thiazide diuretics acts on the DCT and CT, helping in excretion of excess fluids.
Okay. So regarding the causes of confusion and hypoxia, you did a bit of confusion.
Yes, sir.
So for causes of confusion, we have the hyponatremia, which will result into cerebral edema, hypoxia and high
Okay.
ammonia as a byproduct from glycine.
Okay.
And for hypoxia, it is because of the pulmonary edema.
Okay.
Okay,
Okay.
so that these are the two specific reasons for these confusion and hypoxia in this patient.
Okay, sir.
And regarding the management, try to work it out like it was a weak point in this scenario.
Okay.
Like you have to manage the patient overall. Like you will be managing the overall condition. You will be managing the hyponatremia, the confusion, hypoxia, everything. You have to touch everything in your management.
Okay, sir.
Yes. So this is your next scenario. Review it and then we will continue.
Yes. Yes, sir.
Okay, so what are the causes of post-thyroidectomy hypocalcemia?
That can be due to injury to the injury to the parathyroid gland or ischemia of the parathyroid gland, or accidental excision of the parathyroid gland,
Okay,
or
so how
the injury to the inferior thyroid artery.
okay. So how is calcium transported in the blood?
50% is transported in the ionic form. 45% in bound to the albumin, and rest 5% is in the associated with citrates, like.
Okay, so what is the
Yes.
physiological role of calcium in the body?
Um, Calcium helps in neuromuscular functions, then muscle contraction, neurological functions. It helps in mineralization of bone. It helps in wound healing. Then
Anything else? Hello?
yes, sir. Yes, sir. I finished.
Okay. So what are the hormones which are involved in the calcium homeostasis?
The parathyroid hormone, vitamin D, and calcitonin.
Okay, so kindly tell in a short summary that how these hormones work.
The parathyroid hormone is secreted from the parathyroid gland in response to decreased calcium levels. And the vitamin D3 is formed by absorption onto the skin. Then it in the form of cholecalciferol. Then it is acted by 25 hydroxylase enzyme to form 25 hydroxycholecalciferol, which is converted into 24,25 dihydroxycholecalciferol and 125 dihydroxycholecalciferol in the in the liver. Then the vitamin D helps in the absorption of uh, calcium from the gut, and it also helps in the absorption of calcium from the renal tubules. Mm, yes, sir.
Okay. So how vitamin D3 is formed?
Mm, from dehydrocholesterol, the vitamin D is absorbed from the skin. Then it is converted into 25 hydroxy cholecalciferol with the help of 25 hydroxylase enzyme. Then it is 25 hydroxy cholecalciferol is acted upon by the enzymes 1 alpha hydroxylase and 25 hydroxylase to form 125 dihydroxycholecalciferol and 24,25 dihydroxycholecalciferol respectively. Uh, yes, sir.
Okay, so what are the signs of hypocalcemia?
The convulsions, arrhythmias, tremors, and spasm and numbness in the fingers.
Okay, so which muscles are you most worried about if tetanic contractions happen?
Mm. Laryngeal muscles, because it can lead to laryngeal spasm.
Okay, and how will you treat hypocalcemic tetany?
Uh, Calcium gluconate IV, 10 percentage, 10 ml over 10 minutes. Then to correct the tetany, and if needed, we can also start the patient with calcium carbonate uh, tablets.
Okay.
Then, yes.
Again,
Then in, yes,
just work on the management and the treatment options. Okay. So rest of the
yes, sir.
station are okay. Just try to
Yes, sir.
focus on the management because these questions have more marks in the station.
Okay, sir. Okay, sir.
Okay, so this is your scenario. Kindly review it.
Yeah, yes, sir. Yes, sir.
So, what could be the causes of this specific clinical picture?
It could be due to gastric outlet obstruction, um, leading to the symptoms.
Okay, so tell me about the benign and malignant pathologies behind gastric outlet obstruction.
Benign can be due to pyloric stenosis, then the malignant can be due to pancreatic causes and peptic ulcers.
Okay, so what is the clinical picture of gastric outlet obstruction?
Gastric outlet obstruction presents with left hypochondriac pain, dehydration, and multiple episodes of vomiting, which is non-bilious in nature.
Okay, so can you tell me what is going to be the abnormality in the ABGs?
In the ABG, there will be hypochloremia, hypokalemia,
No, only in
hyponatremia.
the ABGs, not
In the ABG,
biochemical.
there will be, yes,
What is the
metabolic
pathology? Yes.
alkalosis.
Now tell me what are the biochemical abnormalities?
There will be hypochloremia, hypokalemia, and hyponatremia. Then hyperkalemic metabolic alkalosis associated with paradoxical aciduria.
Okay. So give me the reason for the development of hyponatremia.
Uh, because the since there is increased bicarbonate levels, the body tries to excrete the bicarbonate levels, but along with the bicarbonate, sodium is also excreted, leading to hyponatremia.
Okay, so why bicarbonate is increased in this scenario?
Uh, because there is loss of chloride levels. Uh, so, in order to balance the loss of chloride levels, bicarbonate is being reabsorbed. The other causes decreased secretion of the pancreatic juices, leading to its retention and increased levels of bicarbonates.
Okay, so give me the reason for the paradoxical aciduria.
Um, the When there is hyponatremia, there will be loss of potassium also. So the potassium is reabsorbed by excretion of H plus ions, leading to paradoxical aciduria.
Okay. So what will be your management for this scenario?
Uh, I will first inform the ITU registrar, then the surgical team, and the gastroenterologist. Then I will send for blood investigations like full blood count, urea and electrolytes, and also the urine sodium osmolality and serum sodium osmolality. I will also check the ABG and I will replace if the patient is dehydrated, I will start the patient with IV fluids, preferably 0.9 percentage
Normal saline.
hypokalemia. I will add potassium. Yes, so not with normal saline, added K plus. Mm,
Okay.
Then I will do continuous cardiac monitoring in this patient.
Okay. So can you tell me what will be the clinical picture of hyponatremia?
Mm. In hyponatremia, the patient will be having confusion. There could be convulsions as a result of severe hyponatremia. Mm, then,
Yeah. So can you
yes.
tell me what is chloride shift?
Chloride shift is the um, shifting of the chlorides into the RBCs and movement of bicarbonate outside the RBCs.
Okay. So in this scenario, this is one of the few scenarios where apart from management, other questions are way more important. Okay. So
Okay.
you have
Yes.
to know the reason behind everything. Why bicarbonate is more, why sodium is
Okay.
less, why there is
Okay.
paradoxical aciduria, and how will you manage? Now,
Okay, sir.
in this scenario, hyponatremia questions can also be added.
Okay.
Though I tried to make a separate session for that, but it can be tested here as well regarding its clinical
Okay, sir.
picture, regarding investigation, regarding management, regarding classification.
Okay, sir.
Okay. So this was all
Yes.
about today's session. Any questions?
Um, yes, nothing, sir. Um, in the videos, I think I saw, I was not clear about the absorption of